The typical progression of arthritis is, the way I explain it to patients is, it's like driving on a road with potholes on it.
Yep.
If you don't repair the potholes and you keep driving on the road, the potholes spread out.
Welcome to the Motion Lab, the podcast that explores the science of movement and helps you live a stronger and healthier life. Welcome back to the Motion Lab. My name is Chuck Dowell. I'm one of the physician assistants here at Colorado Springs Orthopaedic Group. I'm here with Dr. Forrester. He's one of our total joint arthritis specialists.
Yes, sir. Yep.
How long have you been here?
I have been practicing orthopedics now on my own for 7 months, but 7 years in total.
And remind me, where'd you come from?
Originally from Amarillo, Texas, trained throughout the South as well as Salt Lake City.
Come here because of the skiing? Is that?
Came here because I've got family ties actually down near La Veta, Colorado, and just grew up coming here and always loved Colorado.
Excellent. Well, Dr. Forrester is a specialist in joint replacements and arthroplasty surgery, and we thought it would be good to do a talk on arthritis and the importance of arthritis and the different types of arthritis. So when you see somebody in clinic and they say, what is arthritis? What's your kind of answer to that?
So arthritis, kind of just the basics of it, just means inflammation within a joint. So you can have inflammation in any joint in the body, and there's a whole lot of different types of arthritis. Yeah. I'm sure that's the next question. The kind of most common is osteoarthritis, which is normal wear and tear. There's a genetic component to it, but a lot of it has to do with kind of how you've lived your life. And then rheumatoid arthritis is probably the second most common, which is an inflammatory arthritis. It's caused by your body actually attacking its own self.
And some of the ways we're able to differentiate those arthritises are what joints affected, correct? Sometimes the symptoms can help us to differentiate it, but also what joints affected. So let's say from an osteoarthritis standpoint, which is kind of what you see the most of, what joints typically is osteoarthritis affecting?
So it definitely has predilection for certain places. Knees are very common. Mm-hmm. Hips are about half as common as knees. There's some real kind of weird spots that happens very frequently though. The CMC joint, which is this joint right here in your thumb. Yeah. And then your MTP joint, which is the metatarsophalangeal joint, is kind of the big joint on the big toe. Yeah. Yeah, exactly. Yeah. Shoulder, but it can happen anywhere again.
Yeah, so weight-bearing joints are probably the most common, right? Because they're getting a lot of overuse. So it tends to be an overuse, obviously genetic component, as you said, but sometimes overuse. Previous injuries can predispose you to it as well. So if you have a previous knee issue, you can have that down in the future. Yeah. And then from a rheumatoid arthritis standpoint, that's always difficult as well, but sometimes that affects more the hands, correct?
Yeah, exactly. Hands and the feet and the cervical spine.
It's hard for us to tell the difference between the two types of arthritis. We can tell on x-ray, but sometimes laboratory tests as well can help us with that. So if you are unsure what type of arthritis you have, you can come in and we can do x-rays, and potentially that can lead us to that diagnosis. We may send you for lab tests to kind of define that as well, correct?
Yeah, exactly right.
What are the common symptoms when somebody comes in complaining of symptoms consistent with arthritis, let's say of the weight-bearing joints, because your specialists are the kind of knees and hips? What are the common symptoms you see with patients coming in for that?
So by far and away, the most common symptom is pain. And it's pain using whatever the joint is. Second most would be stiffness. So, when somebody has CMC joint arthritis, they have a whole lot of trouble opening jars and things, anything that requires movement of that specific joint. Same thing for hips. You see stiffness first, and honestly, stiffness actually is the earliest sign of pain, usually shortly follows. Yeah.
And I think one of the things I get a lot, or a couple questions I get a lot, because I'm in the express care downstairs and I see kind of acute on chronic complaints, is number one, I've never had pain in my joint before. The pain just showed up now, but when they come in, they have an x-ray that shows arthritis. And oftentimes we can have joints or that are quite quiescent. They're not symptomatic. What are your thoughts, and how do you explain that to patients of arthritis is a progressive disease? It didn't happen overnight in the 2 weeks you've had the pain. Yeah. It's progressed over time, but why wasn't it symptomatic previous to that?
That's a great question. And so it affects everyone differently, but it's one of the most common things I hear from patients, and something I've learned from just seeing a lot of people, is arthritis comes in flares. Yeah. So you oftentimes will have good weeks and bad weeks, or good days and bad days. Oftentimes swelling comes along with it. So the joint will actually get what's called an effusion, or fluid within the joint. And the typical progression of arthritis is, the way I explain it to patients is, it's like driving on a road with potholes on it.
Yep.
If you don't repair the potholes and you keep driving on the road, the potholes spread out. So arthritis, typically it's a slow progression, and slowly deteriorates the cartilage, which is the smooth, lubricated surface of the joints in all of our body. That's the disease part in arthritis.
Yeah. And I kind of, the way I explain it, which I think is very similar, is we all have kind of a line in the sand of pain that we can tolerate. That's just our everyday life aches and pains, right? And it's just a forethought or an afterthought of pain that we have. We wake up and we know we have it. And we don't necessarily have to do anything about that. In our mind, other things are prioritized over it, right? Life and kids and work and things like that. But at times it becomes more symptomatic and it becomes more prioritized in our brain, and it goes above that line of tolerable pain. And that's when we end up seeing them in clinic. And it doesn't mean it hasn't been progressing over that time. It's just been progressing in the background, and it's been tolerable or not present for you to even consider treatment for.
Absolutely.
And so that's kind of how I try to explain it to them. The second question I often get is, what did I do to get the arthritis? How did I get it? So what are the major risk factors that people have to develop osteoarthritis?
So for osteoarthritis, which I guess we skipped one form of arthritis, post-traumatic arthritis. Yeah. So if somebody has a bad injury or something, they've damaged their cartilage, and they have a pothole, we'll say, of their cartilage, it can spread out within the joint. But specifically for osteoarthritis, which is different, I'd say the number one factor is genetics. Your mom and your dad had knee replacements and hip replacements, and you're Scandinavian descent. Yeah. You got a high likelihood that you're going to have arthritis.
Perfect. Thanks for that good news.
Yeah, exactly.
Norwegian, and I have, both parents have replacements. So great, good news. Okay, go ahead.
So that's the number one. And then second being for osteoarthritis is it's age. So it's, you're not born with arthritis. So it's probably some rare conditions in which you are, but not what we're talking about today. And it's a progressive thing. As the cartilage deteriorates, it spreads. So it's a disease of age, and definitely there's a genetic component.
Yeah, and I think those are the major two things. Weight plays a little bit into it, but not significantly into it. But there is a little bit of component of the heavier you are, the more pressure you're putting across your joints. I mean, we all use the same terms of 3 to 5% your body weight, kind of going up and down stairs and arising from seated positions. That can affect the joints. And so
3 to 4 times your body weight.
Correct. Yeah. So, we tell patients for every 1 pound you lose, that's 3 to 4 pounds off of your knees. So 10-pound weight loss is 30 to 40 pounds of pressure or load across your knees that you can reduce. So that definitely, I think, plays a role into it as well.
Yeah.
And then you mentioned the post-traumatic, and we see that quite often is when they were young, in their 20s, they had a surgery, let's say a simple arthroscopy with a cleanup of the meniscus, and then 20 years later they come in and see us with dull, throbbing, aching pain in their joints, and that's that post-traumatic arthritis.
Exactly. Yep.
Another question I get a lot, and this isn't written down, so you're going to be surprised by this one, but I think you have an answer for it, is why is the pain always worse at night? Do you get that question a lot?
I do, yeah. And I don't know that I have a great answer for it, other than when you lay down in bed, you notice the aches and pains from the day, and you feel the throbbing in the knee. Maybe it's your body trying to heal itself, but it's very common to hear that.
Yeah, nighttime pain is always the worst, especially with arthritic or I think inflammatory pain. As you said, I think it's a culmination of the inflammation that's progressed throughout the day that kind of is accumulated towards the night. And number two, the pain becomes more prioritized at night, right? During the day, you have the distractions of life and the day and all this other stuff. At night, those distractions go away, and the only thing you have as a priority in your brain is kind of the pain or the achiness of the joint. And I think that's where maybe sometimes the pain gets worse at night. So regarding, let's say they come in and see you and they say, hey, and you explain to them you have some mild to moderate arthritis or arthritis within your joints, and they say, well, pickleball is my favorite sport. It's my life. I want to do it. I want to stay active. I want to be able to be active and play sports. What's your recommendations regarding playing sports and being active with arthritis?
First of all, I think personally, when I meet a patient who's passionate about something, I say, maybe there's some exceptions to this, but you should absolutely keep doing what you love. Yeah. And, don't try to let this get in your way. Try to figure out interventions that we can do to help them so they can continue to do the things they love.
Yeah. And I think that's always our goal. Our goal is never to have them stop doing the things they love to do. Our goal is what can we do to allow them to do those things, correct? I mean, I think that's the way we always think about it. When somebody comes in and if they have a passion, our goal is not to take that passion away from them. It's to see what we can do to allow them to participate in it. Now, they may have to participate in a modified fashion, as we were talking about, maybe more low impact exercise, not as much high impact exercise, maybe
doubles tennis versus singles.
Exactly.
Yeah.
Maybe not running as much. I'm not doing 10Ks, I'm doing 3 to 5Ks, and I'm running maybe once a week, but cross training the rest of the time, but still allowing them to participate in those activities.
Absolutely. Yeah.
So as far as things we can do, modifying things we can do to allow them to do that, what are the conservative, the non-operative treatments we have for arthritis?
First, we can talk about bracing. So I have a lot of patients who come in specifically, can't brace the hip well, but for knees, they come in with elastic sleeves. And, if they say it works and it helps them, I say continue to do it. There's not great data on it. There's very special customized braces, which are called unloader braces, medial unloader braces, lateral unloader braces, which help change the joint reactive forces depending on if you have one worn out compartment versus both. So sometimes we can get people fit for braces that help them to continue to do things they like. Medications, so we're kind of talking about that earlier. As far as the non-prescription supplements, again, there's not great data on that. You mentioned chondroitin, glucosamine, fish oil, magnesium, turmeric, CBD creams, Voltaren gel.
Correct.
Honestly, I meet people who try a lot of these remedies, and sometimes patients find a remedy that works well for them, and I tell them continue to do it. Again, the data is not great. The data on the supplements like chondroitin, which is a building block for cartilage, it's not good. It might be a placebo effect, but if somebody says they take it and it makes them feel better, I tell them continue to do it because you're not hurting yourself doing it.
Yeah, there's no harm into taking the supplements, and you potentially will get benefit out of it. Obviously, everybody reacts to medications differently. I mean, we all have our favorite allergy medication that works better for us compared to the other people. We all metabolize things differently, and some people say, yeah, I take those joint supplements and they help me quite a bit. And some people say they don't do much for them. Again, as you said, they don't have any harm except for maybe to their pocketbook. I usually recommend to try them for about 2 months. If you haven't noticed a benefit after 2 months, it's probably not worth trying or taking anymore. That's usually my recommendation. And then over-the-counter anti-inflammatories, right? So we have ibuprofen and Tylenol.
Yeah, and those actually probably have the best data on them. Patients are hesitant sometimes to take them, and if you're taking them in high quantities, then they can affect your liver and your kidneys. But taking them within a reasonable dose, as counseled by your primary care or by an orthopedic surgeon, I think they're pretty safe medicines. There's also prescription dose NSAIDs that we do commonly prescribe, especially if someone's trying to avoid surgery or do activities that they love.
I often see this and I ask patients as far as what dosage are you taking. So just to help clarify, or maybe as a general recommendation, it differs depending upon body weight and metabolism stuff. What's your recommendation as far as how much ibuprofen I should take, how much Tylenol, or let's say ibuprofen and Aleve together as they're the anti-inflammatories?
Yeah, so ibuprofen, the prescription dose is 800 milligrams 4 times a day. You should not be taking that quantity of ibuprofen unless you're being instructed to by a physician or it's prescribed to you.
Or monitored,
Monitored, yeah. And, even the patients that I prescribe prescription NSAIDs to, I tell them you should take this during a flare, take it 3 weeks out of the month, but you should always give them a week out of the month where you're off of it for your kidneys to rest. So I think, a safe dose of ibuprofen is probably 600 milligrams, assuming you have good kidneys and you know that you have good kidneys based on your primary care physician. 600 milligrams 4 times a day max, and that should only be taken during a flare for about a week, and then you should not be on that dose for more than about a week.
Yeah, and there's some good literature out of the dental kind of studies that show there's not much difference between 600 and 800 when they kind of did some comparisons. So I agree, I don't really often recommend more than 600. As far as the ibuprofen, and as you said, 3 to 5 or 5 to 7 days max, consistently taking it. before you get concerned about side effects. And make sure you consult your primary care, because some primary cares don't want you to take it for multiple reasons: kidney reasons, heart reasons.
If you're on blood thinners. Yeah.
Yeah. So consult your primary care before doing that consistently, as not to cause any side effects. And then what are our other alternatives from a non-operative? So let's go into injections.
So as far as injections, there's a few different types, and they're not all FDA approved to do in every joint. So the 3 injections that we do here and that are kind of the most common, corticosteroid injections, hyaluronic acid, or what some people call rooster comb or gel injections.
The chicken injections,
Yeah. And then the last one is platelet-rich plasma injections, so PRP. And, I talk to patients because all 3 are approved for the knee. Only the first and the third are approved for the hip. Hyaluronic acid is not approved for the hip. I don't think it's approved for the shoulder either, but don't quote me on that because I'm not sure. But yeah, so there are different types of injections. So corticosteroids kind of tried and true. It's been done for a long time. Some people have hesitations about doing it. When you're using it in a local fashion, meaning right targeted into the joint, it has very little systemic side effects. It's a really potent anti-inflammatory. So if someone's got severe swelling, really bad arthritic flare, they're in the urgent care or the emergency room because they're in so much pain from arthritis, then it's a great medicine and it can really help. It will always wear off. It usually lasts about 3 months. If you get more, that's great. If you get less, you should expect less every time you get another one. So yeah, hyaluronic acid, that's the second one we talked about. So that's our body's natural lubricant that our body uses to lubricate the joint. And basically we can inject it in a high concentrated fashion into certain joints. And it acts as a lubricant. It's not an anti-inflammatory, so it usually takes a little longer to work. It doesn't work in everybody, but for some patients it works really well. And it can last 6 months for some people. So, I've seen good results from patients getting visco supplementation or hyaluronic acid. And then the last one, PRP, that one I'm still on the fence about. It's still considered experimental, but it's a unique treatment. So we actually draw the patient's own blood, centrifuge their blood, and get out just the platelet-rich plasma portion of it, which is this white, almost looks like honey. And it has all of the healing factors of our blood that we can inject into the knee. So it's got healing factors and anti-inflammatory factors. So PRP, there's a lot of research being done on it right now. It's being used for lots of ailments, not just arthritis.
Tendinopathies and
Yep. And it's got a promising future, but it's still early to tell how well it works.
And all of those are available. We have those in your office are available. In the Express Care, I have the cortisone injections available. I think one of the big things I try to reiterate to patients, which I'm sure you do as well, is none of these injections are stopping arthritis. They're not curing arthritis. They're not regrowing cartilage. We've never been able to prove any of that. We're treating the symptoms of arthritis, which are pain and inflammation. And I think that's the important thing to get across to patients, is that we're trying to treat the symptoms of arthritis with these injections, correct?
Exactly. Yep.
And so if somebody comes in and we've tried the anti-inflammatories, we've tried the modified activities, we've lost the weight, we've done the injections, and nothing is working anymore, we've gotten to the point where maybe surgery is the answer. You do a specific surgery, so muscle sparing surgery. Tell us more about that.
For knee replacement specifically, there's a procedure that's been done for decades now, but it's called the medial subvastus approach to the knee. It's being branded as what's called the Jiffy knee these days, which makes it sound like it's a new novel technique, but it's not. It's been done for a long time. Basically, it spares the quadricep tendon, so and the entire quadricep muscle belly. So quadriceps consists of 4 muscles and a big tendon that inserts onto the kneecap. The most surgeons in the country that do knee replacements cut straight along the lines of the fibers of the quadricep tendon and split the vastus medialis obliquus from the other 3 muscles as they do a knee replacement. There's a technique called the medial subvastus where you actually just pull the whole muscle belly over to do the knee replacement, and it leaves the whole quadricep mechanism intact. I've done hundreds both ways, and I seem to see faster results as far as recovery and strength return doing the medial subvastus approach. So it's something that I personally enjoy. I think it's similar to talking about doing an anterior hip replacement versus a posterior hip replacement.
Yeah.
6 weeks down the line or 6 months down the line, there may not be a difference.
Yeah.
And the data probably would show that. But early, my patients do better when I do the muscle sparing technique, but I don't do it on everybody.
Yeah, so it has to be the specific patient that meets the criteria for it. And as you said, the benefit for it is that the recovery is a little bit quicker. They gain their motion a little bit faster. They have a little bit less pain because you're not going into that quadriceps tendon. So they're able to move the leg a little bit quicker, which then allows them to progress through the recovery faster.
Yeah, exactly.
We can do a lot of knee replacements as an outpatient procedure, right? So they can come and go home the same day or be on observation for 23 hours, correct?
Exactly. Yep.
Normally, patients are walking on it right away afterwards. That's one of the benefits of it.
Yep.
And what would you say is a recovery process after, let's say, knee replacement first? What's a normal time frame for recovery, just so there's expectations they would know?
Yeah, knees are hard. So knees take a while to get better. I tell people to expect that for 6 weeks, they're going to be in the same amount of pain, if not more than they were before they had a knee replacement. From 6 weeks to 3 months, typically patients get all their range of motion back. And that's generally when they make the most strides, as far as they say, I'm glad I had a knee replacement. I feel better than I did beforehand. But a knee takes a while. I see knees improve all the way out to a year. It's a quick improvement over the first 3 months, and then it's a slow, gradual improvement up to a year.
And then hip replacements are a little faster because of the mobility of the joint. They just tend to work a little bit, not work better, but recover a little faster.
Absolutely.
And it's time frame as far as a hip replacement?
So, everybody's different, but routinely I'd say the majority of my hip replacements return to the 2-week visit in less pain than they went into surgery in. A lot of them wake up in less pain than they went to sleep with.
Yeah.
From the surgery. So hip replacement, it's my favorite surgery I do because patients do fantastic.
They do great.
For the most part. There's obviously risks of surgery.
Mm-hmm. I think the important thing that we try to get across to patients is that surgery is not the number one option. It's the final option if we failed all the conservative options. And so if somebody comes in with arthritis, we try to go through this algorithm of treating it conservatively with the medications, the modified activities, the weight loss. We try the injections, and then the surgery is we don't have any other options, but we still want to allow them the quality of life and the lifestyle and the activities that they want to do. And that's our way to be able to allow them to still do that, because patients can still be quite active with knee and hip replacements, right?
Absolutely. Saw a guy in clinic who's snowboarding on his 2.5-month new hip replacement last week.
Tennis, pickleball, hiking, snowboarding, skiing, all those activities are still available on the joint replacements.
For me, yes, I think you have to be realistic. If you couldn't do those things beforehand, you're not going to be able to do them afterwards.
True, yeah.
But
very true.
But if you're able to do it, and that's your joints what's hindering you from continuing to do it, absolutely, I'll let patients do those things.
Any final thoughts? Any other kind of advice you give to patients that come in with arthritis? Just kind of, when you're teaching them about what is arthritis and how to navigate the road of having arthritis?
Great question. I think you kind of hit the nail on the head when you said surgery is the final option. You can't undo a knee or a hip replacement. I think that's exactly right. We have this algorithm that we go through. We try this, and then work our way through it. And ultimately, when your knees wake or your hips are waking you up at night and they're interfering with your activities of daily living, and you've done all the other things, I think a joint replacement's a great solution to that and an option for some patients, not everybody.
Yeah, I think it's the last option, but a great option to still allow them to be active and have pain reduction and maintain their quality of life and their lifestyle the best they can.
Yep, absolutely.
Excellent. Well, we appreciate you joining us on the Motion Lab podcast. We hope you enjoyed this episode regarding arthritis. If at any point you have pain in the joint, dull aching pain worse at night, or you think it's arthritic pain, you can come into the Express Care and we can check you out. You can see Dr. Forrester in clinic and he can examine you, discuss more with you regarding your arthritis and the treatment options.